I am David Agus. I am a professor of medicine and engineering at the University of Southern California and the author of the book, The End of Illness.
We've seen the involvement of highly targeted therapies since Gleevec, and since then, lots of special therapies exist, yet the effects on overall survival are poor compared to standard chemotherapy. Where do you see cancer treatment evolving in the next 20 to 30 years?
You make such an important point, which is over the last decade, really the effort has been to target one gene or one protein. And while it's worked, there's some standout examples like the Gleevec. There are very few of them. In most cases, it buys weeks to months. And so it's akin to if you're driving from New York to Boston and you look at the car, take apart it totally, look at every piece, it's not going to tell you how long it takes to make that drive. And so you don't know the weather, the traffic, how much caffeine the driver drank, the bladder size of the driver. You don't know any of that. And so when we only look at the DNA of the cancer, we have one piece to the puzzle. Remember, the cancer isn't an infectious disease. It's not from without. It's from within. It's the body intersecting with itself. So I really believe the next generation of cancer therapies are going to change the system. There's one that we use regularly with dramatic results that builds bone. And by changing bone, you take breast cancer and prostate cancer, you dramatically change recurrence rates because breast cancer and prostate cancer go to the bone. And if you change the soil, the seed doesn't grow. So I think more and more efforts to start to change the system so the cancer doesn't want to grow are going to replace the reductionist notion of hit one gene, one target.
Okay, so can you go a bit more into what the most common misconceptions about cancer are currently?
I mean, that's a broad question, but there are things like people say, well, can you sequence my cancer to know what drives it? Well, the average cancer on diagnosis has 400 to 500 mutations. So it is really impossible to target all of them, to know what they mean, even to build a model around it. So it is a very complex disease in that regard. The other notion people always say is, well, we're going to target the immune system to it. Remember, cancer cells and normal cells look very, very similar to the immune system. So for over 100 years, we've been trying to target the immune system to cancers with very little success at all. Slight success in some melanomas and some kidney cancers, but that's about it. And the reason, again, is that they're so similar to normal. So I really think the big revolution in cancer is to stop treating it like an infectious disease, like germ theory, where germ theory says if you look under the microscope and see what the bug is, you know how to treat it. Well, cancer is not like that. It's this complex system of you and it. And so the next generation will be changing that system.
So it's actually also more of a philosophical shift that needs to happen, yes?
Oh, yeah. I mean, listen, we have to get away from this reductionist notion. And we always want to focus on what we're good at. Well, DNA, we're good at. We can look at. So we put all of our efforts there, and we forgot the proteome, the microbiome, the whole system to look at. So we only look at the cancer cell, and we forget everything else because we can. And so we need to get away from that. We need to focus on the data we have and to make it better. There's a pill a day you can take that costs about $3.50 a year that reduces not the incidence, but the death rate of cancer by over 35%. It's a baby aspirin. Yet, very little effort is going into making it better. Very little effort is going into understanding how it works, taking away the side effects. I really believe we need to focus on the small wins we have and try to make them better.
So, your book talks actually a lot about preventative things that you can do against cancer. Can you elaborate a bit more on that? So, you mentioned aspirin, but what are other things that people can do?
Well, I mean, they're the simple things, right? Avoid smoking tobacco. That's a simple one where you can get rid of a dramatic amount of cancer. The other ones may not be so obvious, but things like movement. Your body was engineered to move during the day. So it's not the hour at the gym, it's the rest of the time that you move. I love if you go to the gym for an hour, but you sit the rest of the day. Sitting for 5 hours is akin on a health basis of smoking a pack or more of cigarettes. And so we need you to move during the day. As simple as that will reduce cancer. We need to reduce inflammation. Remember, the two dominant trials we have that show reducing in cancer are an aspirin and a drug class called statins. That's the Lipitor, the Crestors of the world. And both of them work by blocking inflammation. And both of them can dramatically decrease the incidence and the outcome of cancer. People on a statin who get cancer actually live longer, was a study in last year's New England Journal of Medicine. So we need to focus on them and reduce inflammation. And the most uncommon sources, that you wouldn't think of, wearing shoes that might hurt you, playing a sport that's every day after you play it, you hurt. That's inflammation, and we don't want that. We want you to know about what you eat. So eat real food. Get off the things like the vitamins and supplements, which, if you look at the data, in general have no benefit and in many cases actually increase things like cancer. In a $250 million study from the government, men who took vitamin E after 3 years had a 17% increase in prostate cancer, which lasted for 3 years after stopping. Smokers and former smokers who took vitamin A or beta carotene had a dramatic increase in lung cancer and death from lung cancer. So eat real food, get off the pills, and change the behaviors that can lead to cancer.
Okay. I think that the relationship between the patient and the physician is anyway very interesting. So, how do you think the role of the patient is actually changing in cancer treatment? And how can patients kind of step up and take more responsibility? And yeah.
I think you hit it with the more responsibility is that in today's world, I really believe it's a team. Your doctor doesn't decide your treatment. Your doctor doesn't look at a pieces of paper and say, hey, I'm going to give drug X or drug Y. It's the team of you and he or she. There is very few times when there's a black and white answer in medicine. You have to use caution with this term in today's world, but it's shades of gray. In most time, it's based on your value system. So I want patients to go in educated, where they know the possibilities and they can sit down with their physician and talk about the merits, the benefits, the side effects, the outcomes with multiple different potential treatment arms and together make the right decision for them. The best care happens when it's a team.
And so, on that note, actually, is psychological treatment being integrated more in cancer treatment? And do you think that's important? And is there room for improvement there?
Oh yeah, I mean, there's an amazing observation, not just in cancer, but across all human diseases. If you look at clinical trials, people with a belief system and an outlook that's positive do significantly better than people with no belief system or a negative outlook. And so putting patients in a sense where they can have and continue their belief system and really look positively to the outcome. So they're in charge of their care, you're going to get the best outcome. And so, me as a doctor, I have to play part psychologist, part tumor biologist, part geneticist, part chemotherapist, all of those to really get the best care of the patient. And so, it's my job to try to understand his or her value system of the patient and then to talk to them based on that value system and rate the right decision so that they have a positive outlook, they understand what they're getting into, and then to deal with the psychological aspects. It is an area that is way too often overlooked because there's no measurement for it. I don't have a blood test for your psychological state in a moment. And so it's very hard. I can ask you a questionnaire, but I don't know how to grade it. I can't put you in A, B, C, D. It is very subjective. And so classically in medicine, those kinds of things get pushed to the side when we can't describe it or give it a number.
So there is in general actually a lot of discussion around empathy in physicians. And I think there's sort of a lot of pressure that I guess physicians should be more empathetic. But I think like how much responsibility and how much importance should should lie on the physician to be empathetic, or do you think that's they're actually so the life of a physician is so busy that sometimes a bit too much is expected from them?
Well, listen, the role of the physician is to be a caring individual, to educate the patient, and together get the best outcome. And the role of empathy or things along that line can vary. Some patients want physicians who are empathetic, others want them who are just dictatorial. It really is your value system, and you're going to choose the physician that's based for you. And I think we have to get away from the notion is I'm going to go to who my doctor referred me to and actually talk to people and do the research to get a doctor that you bond to. You're putting your life into his or her hands. You really want to get someone who you respect and you have the same value systems and you get each other because that kind of relationship will have a good outcome.
Um, just one final question, actually. Do you think that oncologists are more prone to depression and loss of happiness? Because it's kind of a very difficult job in a way, I guess, sometimes.
Listen, every field also selects for who goes into it. I think people who go into oncology go into it for a reason, and it selects a certain type of personality. So I actually don't see a lot of depression in the field. I see a lot of optimism and hope, and most of us pinch ourselves for what we do in that we can help people every day. Even if they don't do well with their cancer, I can help them spend their last weeks, months, years with dignity. I can give them quality time with their family, and it is honestly an honor to do that. And I think that's how most oncologists feel. And, in most spaces, it's not like a certain group go into it. It really selects out for people who feel that way. And so I'm honored to work with my fellow oncologists. And I think all of us look at each other every day and say, we're in an amazing space. We're able to help people at the time where they're the most needy and the most vulnerable and hopefully make them live better.
So, do you have any advice for oncologists embarking on their career?
Yeah, I think the best, the problem with medicine today, right, is we select people who do well in aptitude tests. Well, they scored a 1600 on their SATs or a 2400 on their test. What I want is people who can talk, who can listen, who can observe. The art of observation is going away and it's very hard to teach it. So young oncologists, what I tell them is develop mentors. I want you to work with the 5 or 6 best people you can find and spend some time with them and take a little piece from each of them and then develop your own personality. But I think you have to watch each of those encounters. Medicine is an art, it's not just a science. Malcolm Gladwell, in his remarkable book called Blink, said there are 10 Rembrandt experts in a room, and you put 9 Rembrandts on the wall and one fake, and you ask them which is real and which is fake. They get it right. You ask them why, they can't tell you. And it's the same in medicine, is that I can look at a case and a patient, and I have a gut. This cancer is going to be really hard to treat, or I can really get a hold of this cancer. And much, if not most of the time, we're right. And I can't always tell you why. I can't tell you this gene is on, this gene is off. It's the fact of doing something and keeping the eyes open and observing really brings this skill to the art of medicine.
Thank you so much, Dr. Agus. This was great. Everyone can hope to have such a great doctor like you. And I wish you a very nice day.
You too. Thank you so much. You were
Thank
great.
you.